Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Recording in progress.
4 billion.
Okay, the actual number is 1.2 billion people are living with hypertension.
That's good.
That's not good at all.
But it's good considering what we thought.
Oh, you're right. Right. Yeah, you're right about that. Yeah. Well, there's an alarming message for us that about 2,000 people a day are dying from COVID still. And we're approaching 700,000 people dying in the United States from COVID. So we have to be careful. Cheryl, did you get your third shot yet?
No, I didn't get the third shot yet. The dialysis center said they're going to have it, but I'm not sure when. But I'm going to try CVS up the street. The first time they canceled my appointment, so I need to see what happened.
Okay, it's 9 o'clock. So we're blessed today by having Dr. Kirk today, who is a podiatrist of national and international renown. Actually, he was the president of the, what's the name of the podiatry group in the United States? The American Podiatry Association, is that the group you led? Yes, okay. He's the first African-American to have that kind of position. And I've worked with him for decades, and we talked a lot about leadership and the distinct role that pioneers like him play in the field of medicine, especially in podiatry, where it's a good old white boy society. And so since he's done such a great job in taking care of my feet and the feet of my patients, I wanted him to talk to you about what he's been doing for a while. And with that, I'll turn it over to Dr. Kirk, Assistant Professor, College of Medicine, Chief Division of Podiatry, who's been a good friend and a great doctor for quite a while.
Welcome.
Thank you. I hope you can hear me okay.
We hear you well.
Good. It's always a pleasure to talk about something that I enjoy talking about, and anytime I can put a soulful thing on it, we'll get on the good foot. I think that's a good thing. So I wanted to spend a few minutes just talking about some things that I thought would be helpful for anyone, especially this group. We're going to look at some facts, some things, some common foot problems. Over the last 10 years, people have been getting infections more and more from getting pedicures. So we'll look at some do's and don'ts related to that. And then try to open up for some questions if anyone has any. Just like any other part of the body, the foot is very complex. Most people tend to forget about their foot until they have a problem with it. And then all of a sudden they pay attention to it. Just like a lot of things that we all tend to do in a fast moving society. But there's a lot of bones, as you could see, and we only get one pair. It's not like tires on a car, so we have to keep what we got. And my job is to make everybody's feet happy. So as you heard Dr. Callender say, that's what I try to do. A couple of years ago, it was thought that according to the Podiatry Association, 75% of all Americans would, during their lifetime, get some foot problem of some type. And as you can imagine, with the type of shoes that women wear, women tend to be more prone to those kinds of complications. It's interesting that most of us don't think about it, but the average person on a daily day takes about 8,000 to 10,000 steps a day. And if you look at that over a lifetime, it actually totals up to over 100,000 miles in a person's lifetime. And if you're involved in any activity, especially running, tends to be a little bit more of your average body weight. So if a person weighs 200 pounds, then they're putting 3 to 4 times more pressure on their feet. So if a person is overweight and small stature, you can see how over time that can create problems not only in the feet, but the knees, the hips, and the lower back as well. Before we talk about diabetes, I wanted to talk about some other things as related to what we can do on a daily basis. Most of us tend to think about our feet as getting up in the morning, taking a shower, drying things off, and going about our business, putting on our shoes. But daily foot inspection is very important, whether you do it at the end of the day or the beginning of the day. What you want to do is you want to take a few minutes to look between your toes. If you have a problem reaching down, then the best thing to do would be to sit in a chair in a well-lit area and take a handheld mirror and use the mirror to look at the bottom of the feet and in between your toes. So even the average person, as they get older, has a problem bending their knees, so that will help a great deal. Most people tend to ask, well, what should I wash my feet in? Well, any type of antibacterial soap that you would use in the shower or the tub is probably the best way to go about that. You want to make sure if you test the water with your elbow, especially if you have some disease process that may cause complications with sensation. And most people tend to not moisturize their feet. We get up, it's a fast moving pace. We tend to just put our socks or stockings on and go about our business. But with the winter months coming up, it's important to moisturize not only the top and the bottom of your feet, but keep between your toes dry as well. Well, what about diabetes? A lot of individuals who are diabetic or have high blood pressure, like Dr. Callender was talking about earlier, cardiovascular disease, transplant patients, or patients on dialysis, tend to have a lot of problems with other parts of their body that can sometimes put them at risk. Example, some patients who are post-transplant may have delayed graft function, some problems with wounds, infection, rejection, or dehydration. So if they're dehydrated and their skin is dry on the bottom of their feet, then it makes them more prone to infection. So that's where moisturizing comes in really well. Gold Bond makes a great moisturizer for hand and feet. It's not as oily as some of the other products. You can get it anywhere over the counter, and it's relatively inexpensive, and it lasts for most of the day. When I was thinking about this talk, Dr. Callender and I have worked together a lot, but I never really thought about it. But I think it's important too, whether the patient is on dialysis or a transplant patient, to consider their bone stock. As we get older, all of our bones tend to become weaker, and African Americans are more likely to have low levels of vitamin D. So I think it's actually imperative that whether they're a dialysis patient, a diabetic, or post-transplant, that routine foot films are done to evaluate the bony structure to make sure these individuals can continue on with their lifestyle, especially with more and more exercise being talked about and controlling weight and all. I think that that's something to consider moving forward. Even a project to look at that would be great. I think my screen went out for a minute, but the two biggest things I think over the years that I've had the hardest time, and transplant patients, so African Americans tend to make up a large chunk of the diabetic population. And for some reason, women are more susceptible over the age of 55 of having diabetes as well. I think the key for these patients is to do the inspection, daily care of your feet, and um, continue with exercise. It seems like the patients who don't exercise are the ones that tend to run into trouble more so than anything else. And with this COVID going on, what we started to do was to tell patients that if they're at home and confined, to start when a TV commercial comes on, if they're watching TV, to flex their feet back and forth and wiggle their toes if they have shoes on. And also if they're moving around, to get up periodically, walk to the kitchen and then walk back. And those things seem to help over time if you do a cumulative effect. If you get up 3 or 4 times a day, even to go to the restroom, and you have a distance to walk, we're finding that even that little bit of exercise is helping patients a great deal. I think that there needs to be more, there's so much emphasis put on the diabetic patient, but I also think there needs to be more emphasis on the dialysis and the transplant patient. Most people function and say that comprehensive care can help reduce amputation in the lower extremity in the diabetic patient, but I think it also can do the same for patients that have cardiovascular disease, dialysis, and other disease processes as well. So, a lot of times they say, tell a friend or bring a friend. So, today, when you finish this, if you tell your friend, hey, when's the last time you inspected your feet? Have you looked at them? Have you gotten some care? I think word of mouth in certain patient populations is a great way to facilitate and get the word out. Just like people have on their card, it's a donor card, like I have on mine. We need to keep singing different songs throughout our day. Again, self-care is paramount. Last week, I think it was, had a pregnant female patient that had been walking around at home. Everybody wants to walk in their house barefoot for some reason. But covering, especially in individuals with other compromised medical conditions, is paramount. People step on pins, needles, bristles. I've taken out bristles from a broom, a bobby pin that was a diabetic needle for injections of insulin. So if barefoot is your thing, try to compromise by using some type of slipper or covering over your feet. Does everybody on the call exercise at all?
No.
Yes.
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 Little bit.
Certain part,
I'm working every day.
certain parts of the body, I exercise.
Well, walking is probably the cheapest and the easiest to do. We'll look at a couple shoe examples in a little bit of what's a good shoe based on certain foot types. But if you can, even if you working and have a sit down job, periodically get up and move around, especially with your knees being bent. That tends to impede blood flow during the course of the day, and it's significant over time. And with other kidney problems, diabetics, hypertension, cardiovascular issues, those things add up over time. I ride a stationary bike about 3 or 4 times a week, and I walk constantly. Not only during the course of the day, that tends to not be enough. Your body tends to adjust to that. So you want to add to it, even if it's for 10 or 15 minutes during the course of a couple times a week. So that's something that you need to consider. Another thing I wanted to talk about, a lot of times things get missed. Everybody talks about diabetes and kidney disease, but peripheral arterial disease is a big problem too. I'm starting to see more and more patients. We're actually working on a research project that looks at doing arterial studies on patients who have symptoms versus those who don't have symptoms in our patient population, because I think it's missed. And people tend to say, well, I'm having problems or pain in my leg a little bit. It may be related to the fact that I'm getting older, but it may be related to the fact that blood is not getting there as much as it should. So therefore, again, exercise becomes very important. Movement tends to, if you don't use it, you lose it type of event. But let's look at some common foot problems. Toenail fungus is one of the biggest that I see on a daily basis, where the nail will be discolored to some degree or have almost like a white powdery substance on top of the nail. It's a very common problem. What's the fix for it? I've been doing this for 30 years. I don't really know what the fix is for it. There's so many different topical versus oral. Problem with the oral is it can cause problems with the kidney and the liver. I haven't had any patients that have any problems with it, but I don't think it works as well as we would like it to. What's the cure for toenail fungus? Don't get it in the first place, because I've seen nothing that really works. We've used everything from Vicks Vapor Rub to apple cider vinegar soaps to topical medications. The hardest one to treat is when the nail becomes very thick. Its presentation, it's hard to get anything to penetrate the nail plate. Most people want you to take the nail off and say, let me start all over again. Well, most of the time the nail comes back thicker than it was, because I think we don't really address the overall etiology. And I think there's diet and other things that are missing out that aren't really being captured. Stress, person's daily life, other medical things that can lead them to allow the fungus to get there in the first place. Well, how does it get there? Well, the fungus likes moist, dark places to grow. So our shoes are a prime example. So we tell patients to make sure you spray your shoes periodically with Lysol. It tends to keep bacteria, fungus, and mold out of the shoe. Whatever you use to clean your tub or your shower, your bathroom with, look on the back of the product to see if it says kills mold, bacteria, and most fungus. And that usually is sufficient enough. But again, going barefoot is another problem, because kitchen floors, wood floors, they get dirty, so they can create problems. And a lot of times people come into their home and move around in their house and with the same shoe that they've been walking outside with. But since COVID, we've been telling people to clean the bottom of their shoe or spray the bottom of their shoe once they come in the house, because I'm a firm believer that I think the bacteria and stuff from COVID gets transmitted through shoes. And I think that things like that are missed. Ingrown toenails, a big problem. Most people tend to cut their nails too short, and that creates a problem. Overweight can cause a problem with that. Foot odor, people's feet sweat. Some people's feet sweat by genetics. Some people sweat by some of the medications they may be having to take. Usually, if there's no cracks in the skin, a spray deodorant will work on your feet just as well, as long as it has aluminum chlorohydrate in it, like Right Guard or one of the spray deodorants will work just as well. Bunions and Hammertoes, we'll look at those in a second. Bunion is a deformity that is usually on the big toe joint. Most of the time it can be surgically corrected unless the person has some other underlying problems that put them at risk. How does it get there in the first place? In women, usually a tight shoe can be a culprit. 20 to 25% of the individuals have a hereditary factor in their foot. Their parent, the grandparent, someone in their family may have had the same problem. And because of their genetic makeup, just like other things, it makes them predisposed to that, but it can be easily fixed. Hammertoe, I can't think of the movie where Eddie Murphy made this pretty popular, where he was dating a woman and they spent the night together and he pulled back the covers and she had hammertoes. So we were pretty busy with that during that time period. I thought that was pretty funny, but I guess you guys are. So, but it's a structural deformity that where the toe wants to grip inside the shoe and can create problems in individuals, especially with their foot type. Provided that everything is fine, it's easily remedied in a surgical procedure. If the person cannot undergo that, then we try to put them in a wider shoe and give them some padding or some other type of modification to help with that so that they can continue their daily activity. If you're a pedicure fan, it's fine. There's certain things you should know about in relationship to that. We've had several cases where patients have gone to get pedicures and state that they had received an infection afterwards, one where the patient actually had to have a toe amputation because the infection went down to the bone. But most of the time, I tell patients to bring their own instruments. You can go on Amazon and get a pedicure kit that's relatively inexpensive. If patients are diabetic or have other complications, I tend to tell them to stay away from that, of having people to treat it, depending on what their history is, what their blood flow is like. I may allow them to go ahead and get their nails polished without having a lot of other things go on because they can get nicked, and that could create a problem too. And most of the pedicure places, their instruments are only disinfected, they're not sterilized. So you have to be careful of that too, to ask that question. Women should think about not shaving their legs before they go if they're able to go, because the pores, they want to soak your feet, and if the water's not totally clean, they can get a bacterial infection in their legs as well as their feet. Shoes are very important for everything that we do. A lot of individuals want a shoe to match what they're wearing, but most of the time the shoes should match their foot type of what they have. An example of that is I have a wide foot. My foot is a double E. So I can't wear Nikes. I can wear New Balance or Asics, because if you have a wide foot, New Balance or Asics are wider shoes that allow for a better fit. I can't wear Adidas. People who have a very narrow foot, or women sometimes tend to have a very narrow heel, then Adidas or Nike is a better shoe. And if we're talking about exercise, a walking shoe or a cross trainer or a running shoe are better than that. Skechers has recently upped their brand with their shoes too, and they tend to have the insole inside of the shoe, which is appropriate. But if you're going to do an activity like walking, most people wear the same shoe over and over and over and over again. You should alternate the shoe for activity as well as what you do daily. You shouldn't wear the same shoe every day. I have a couple pairs of shoes in my office. I alternate. And if you're at work and you're on your feet, you need to consider, I change my shoes most of the time halfway through the day. Even though they're the exact same shoe, I just change them. I tend to tell patients that if you find a brand of shoe that fits, then stay with that brand. Maybe you get a different style, but the shoemaker doesn't really care what you do. And so if you have a shoe and you look at the bottom of the shoe and you can see the outside of the shoe on both sides of the sole. They tend to make it narrow to cut down on the cost of the shoe. And so a lot of times people will complain of the shoe hurting on the outside of their foot or on the inside, and that's because the size of the shoe itself is not appropriate to what your foot is. And then if you're going to go and purchase a shoe, especially as you get older, every time you go and purchase a shoe, you should stand up and be measured. Because as we get older, our feet people say, my foot got bigger. Yeah, well, it did, because the ligaments inside are looser and the muscles aren't as toned as they used to be. So it makes things spread. So it makes your size go up just a little bit. And most individuals, probably about 50, 60%, one foot is larger than the other by at least half a size. My left foot is bigger than my right. So when I go to get shoes, I don't even try on the right shoe, because if the left foot feels fine, then I know the right foot is going to feel fine. But I'm going to stop for a minute, see if anybody has any questions.
I have a question, Dr. Jeter. Have you seen people's with feet that have poor blood flow in their feet?
Yes. Yeah, just like you have pulses in your wrist, you have pulses in your feet. You have 3 pulses in your feet. One's on the top, one's on the inside, underneath your ankle, and the other one is on the outside. We can feel those pulses and tell a lot of times if there's diminished flow. Other things will give you indications, changing the color of the skin, where the skin might be a little darker in the lower extremity, except during the summer months when people wear sandals, you have to be careful because people tend to get tanned a little bit. Their skin will tend to be drier. And if they have digital hair, they'll have less digital hair. And in some instances, their nails won't grow as fast. Usually, if their nails don't grow as fast, that's the early indication that, because the nails really the last part on the end of the road where blood flow and all gets to in the nerves. So those tend to be indications that a person may be having. Now, on a bigger scale, they may have problems walking. They can only walk a block. Then they have to stop because their leg starts to cramp, or they can only walk 2 blocks. Or when they lay down at night, they tend to say that when they lay down and get off their feet sometime in the nighttime, they get pains in their feet and their legs. So those can be indications of compromised flow to the extremities.
What about plantar warts? Is there really a treatment for that?
That's a good question, because, when I first started, I didn't see African Americans with plantar warts too much. I went to school at Temple, and so our patient population was a little bit of everything, and we tended to see them. But over the last maybe 5 to 6 years, I'm starting to see younger people with plantar warts. There's a couple things you can do. Topical medications, laser, freezing them, or if they're singular, you can surgically remove them as well. So yeah, most of the topical ones, some of the stuff that's over the counter is not strong enough. There's a couple that we use that are pretty good. The younger the person, especially if they have no underlying medical conditions, the faster they tend to be able to get the wart. The wart is a virus, usually spread. People usually get it from at pools, gyms, other places where they might have had a little nick in their skin and the virus is laying around and they pick it up that way. People want to tend to pick them. And when they do that, it tends to make them spread, where they get a collage of them in the area. But yeah, most of the time you can treat them pretty well. There's been some documentation of using duct tape as well. I haven't used it, but duct tape under occlusion to get rid of the wart.
Um,
Go ahead, babe.
oh, thank you. My question is about bunions. I have very pronounced bunions on both of my big toes. And I'm wondering if that, because of that structure of my foot, does that have anything to do with my spine or maybe having back pain?
The back pain may have caused a change in your gait or the way that you walk, and over time could have increased the condition more so than it normally would be. If the bunions aren't bothering the person, I tend to let them go, because if it's not broke, don't fix them. I tend to modify whatever it is that they're doing, because in a case where a person has a back problem, you operate on one or both, and then it makes the back hurt more because you modify their gait for about 2 months. So we need to kind of tread lightly with that just to make sure that everything is okay. But usually, you're right, most of the time, especially lately, seen a lot of people with low back pain that is not necessarily, they're not necessarily correlating the fact that the low back pain and the foot problem are related, but they usually are.
Yeah.
Did I answer your question?
Yeah, that helps. I just had a lot of problems with my back. My bunions, like you said, I've heard people say that you could do surgery, but they don't really hurt unless I have the wrong shoes on for any length of time. But as long as I'm not really, in shoes for a long period of time, I have no problem with my bunions. So I have not tried to do anything surgically, but I have had to have my sciatic nerves and things like that have been happening in my back. So I just wondered whether it was any correlation.
Yes, but shoe modification is the key for what you just said. You're exactly right. I agree with that.
Thank you.
Dr. Jeter, this might
Yeah.
sound a little strange, but I knew someone who periodically, and by periodically, I mean years in between, the nail on the large toe would fall off. It would eventually grow back. Is that a fungus? And would diet have anything to do with it?
I see that a lot in diabetics, or patients with compromised medical conditions where the nail will fall off. I see it a lot in diabetics. It's usually the big toe nail.
Yeah.
It could be also related to micro trauma, making the nail weak. In other words, is half of the population has their big toe is larger than their second toe. The other half, the second toe is larger than the first toe. So if it's getting micro trauma in the shoe, it could be causing that in addition to the fungus. So it could be, those could be separate entities, or they could be all together as well. That could be related to it. And the fact that it grows back is fine. The question is, does it grow back the same way? Does it look the same? Does it not look the same? That would be a question to ask. The other thing is, when it comes off, then if they just use a topical over-the-counter antifungal solution on the nail to see if they can change the way that the nail is growing back. Diet could be related to it too, if they had some other underlying factors that were making their nails brittle, even in their hands as well, certain vitamin deficiencies. So those are things to look at.
Okay, good. Thank you.
Dr. Jeter.
Yes.
I have a question about your alignment of your body. What role does your feet play in how you maintain alliance with your body?
That's a good question. You know, I was watching a football game the other day, and the guy got hurt, his knee, and I was wondering, because if you look at a person, how I look at the patient is, I look at them from their head to their shoulders, to their waist, to their knees, and to their feet. And most people, if their knee is not looking straight at you, then their foot is going to be leaning to the inside. And I think all those things play a part. Example, women tend to carry their bag or their purse on one side. Now, I don't know the answer to this question, but is that the side that most people or females have a problem with on their extremity? I don't know the answer to that question, but most women don't change it from one side to the other. They keep it on one side. Does that have any effect with their shoulder, the muscles and things? I think the whole thing is something that needs to be looked at, just like kids get their ears checked, their eyes checked in elementary school, but they need to have their spine, their lower extremity, their upper extremity looked at too, to see if there's a malalignment, because these individuals that I see that are 80, they didn't start out with their knee being bad, their hip being bad. Something was out of alignment in addition to maybe their job, whatever else they did, those things. So I think they all play a significant role, but I don't think we look at them as much as and they get the attention that they really need. And I see it a lot. I'm starting to see it a lot now in younger people where their knee alignment is out. I think if I don't balance them better in their foot, then as they get older, they're going to get degenerative changes in their knee or even in their hip. But I think a lot of it starts at the bottom, but it's been missed for so long.
Is there anything that we can do to improve, help our feet and the alignment of our bodies?
Know what kind of foot you have in relationship to what you wear. Is probably the biggest thing. If you think about these stilettos that are out now, what's going to happen to a 23-year-old female that, because they're wearing these stylish shoes, they're pushing their pelvis forward, they're pushing their knees forward, they're pushing their ankle joint and everything below forward. They keep doing that. I think a lot of it, I was at the airport the other day and they were wearing slippers. And I was like, wow, slippers at the airport. But if their foot is flat and they're wearing slippers and they have no support, I think it all starts with having a proper footwear for the activity that you're going to do. I love to wear slip-ons. I can't stand wearing lace-up dress shoes. But I know that if I'm going to be somewhere all day long where I need to be dressed, I have to wear a lace-up because my foot swells as the day goes on if I don't work out. And it could be if I'm not able to drink a lot of fluid, I got high blood pressure. So, it might be that I need to drink more water. So biggest thing to do is wearing the proper footwear for the right activity for what you're going to do. Even if you go to an event, a wedding or something, you want to wear something that you consider appropriate, have something in your bag that you can slip work, whatever work requirement you have to wear, and then change back going home. So.
Thank you.
Mm-hmm.
Dr. Jeter, I've had a number of patients I've referred to you who have foot problems, but also people who have cancer in their foot. Can you tell us a little bit about your experience with tumors or cancers in the foot?
I've had maybe about 20 patients over my time. The last one I had was a malignant melanoma patient. Actually was a diabetic, had a ulcer opening on their foot, and it went down to the bone. And the bone was infected. So we removed that part of the toe. And in addition to the bone infection, well, the pathologist picked up that they have melanoma as an incidental finding. People think that cancer can't get in the foot because usually people relate some of those type of cancers to sun exposure and all of that. Well, I've had quite a few melanomas. I shared a patient with Dr. Callender who got missed with having cancer by another outside facility, and subsequently found out that this individual had cancer. I've seen it quite a bit. A couple people here and outside. I think it gets missed because people aren't really looking at the patient as a whole. But you have to be careful. And this patient subsequently, the last one, we wound up having to cut off all their toes because the melanoma was so extensive but it was so slight that you really couldn't see what was going on. So and the patient's doing fine. But oh yeah, it's more than I think people give it credit for. And then the other thing is that patients who have cancer in other parts of the body can have what is called metastatic cancer, where it travels and it can travel to the foot. We're looking at a patient this past week that I think has that condition going on, but we're trying to see, they had cancer, I can't remember where else it was, some other part of their body, but now they're having a lot of pain in their foot. No trauma, no anything going on other than the fact that the significant thing is that they underwent treatment for their cancer. Oh yeah, I think it's more important than, and gets missed a lot, as a matter of fact.
Dr. Jeter, back to the poor blood circulation in the foot. Is there a name for that particular disease?
Well, PAD, or peripheral arterial disease, is usually the name. One of the most significant tests we do or send the patients for is what's called a arterial Doppler with PVR studies and toe pressures, where they put cuffs on your lower extremity, just like you get a cuff on your for your blood pressure. And from that, it gives you some numbers where 1 is good and 0.2 to 0.8 is a problem in most individuals. If it's above 1, it tends to mean that the vessel is open to some degree, but there's calcification within the blood vessel lining that will still allow the blood to go through, but it just gives a higher reading. So that's the initial test that's usually done to get an idea on where to go. And we work closely with the vascular surgery here to try to establish a means by which we can get more blood flow to the patient.
Thank you for that.
Mm-hmm. How often should you see a foot doctor?
It would depend. Diabetics, patients with dialysis patients, other cardiovascular issues, probably every 2 to 3 months. Diabetics that are well controlled, maybe just by diet, maybe every 6 to 12 months. Other high risk, it would depend on the problem that you're treating. But I think everybody should at least get evaluated at least once to find out what's going on. But I'm biased.
Dr. Jeter,
I'm sorry.
just a practical thing. You said that wearing shoes, they should be sprayed, but then you shouldn't go in the house barefooted. And the sock feet is just like barefoot. So what do you suggest? Take off your shoes or spray the shoes or wear sock feet in a house?
I wear those slides, those athletic slides that the different companies make, because I have heel problems. I have plantar fascia. My plantar fascia acts up in my heel. So I need to have something on all the time. So actually, when I come in, I go into the little mud room or whatever, and it's Lysol spray right there. I spray the soles of the shoe I have on. I take them off, and my other shoes are sitting right there. I can't go sock feet either because I have to have that support up underneath me. Otherwise, my heel starts to bother me. It's just like the shoes I was talking about. I tend to wear Asics, but I have to have that piece that's in there that comes out that has that support to it, because I can take that piece out and put another one in. I even have the mules, the Birkenstock mules that have arch supports in them. It's a requirement for my foot because my right foot tends to act up more than my left. It hasn't done it in a while because I started riding a stationary bike more than walking. It has done better since I've been riding a bike, I noticed. But the socks are fine as long as they have some sole on them. I mean, needles and other stuff can get through socks too. So I just try to tell them it's something that's supportive that they can wear. My daughter wears Birkenstocks, the sandals. She slides in those when she goes home. But it's got to be something supportive. And the older you get, especially women, I think it's hormonal in the things that women go through during their life. Most of the women I treat, and I treat a lot of patients, they lose the cushion under the bottom of their feet over time. So you have to replace that. So you have to figure out what you like. As long as it's supportive, it doesn't really matter. But those slides work for me because I'm lazy and I just slide my feet right in them and I go on about my business. I have like 3 or 4 pairs that sit around, and if I'm in a recliner watching TV, there's one pair there, there's another pair someplace else, because it just works. I don't want to go look for them or whatever. So at the end of the day, I tend to be lazy. So
Okay, and
don't tell
the last question.
Dr. Callender that.
Okay. The last question is, there is a guide for what type of shoes that are best. I know women, we go through this of heels and all of that. Or should we have a flat shoe with a small heel? And I know you said you have several shoes that you switch off all day long or something like that. And a certain brand. Is there a guide or something to guide us into? So I wouldn't have to spend all my money trying to figure out whether it's Adidas or whatever to wear, or you just have to go by experiment.
That's a good, I'm going to have to look that up because I really don't think there's a guide, but I can tell you this. Women's shoes, in my experience, should have 2 sizes, the front part and the back part. A lot of women have a narrow heel. So they tend to want to, sometimes they'll put the shoe on, the shoe will feel good in the front, but it'll slip in the back. Or it'll be tight in the back and roomy in the front. Those type of things, the slingbacks are best. Adidas, you said Adidas. If you have a narrow foot, you should pretty much know if you have a narrow foot or not. If your foot is a B, if you're a woman and your foot is a B or A, then that's a narrow foot. If you send me an email, I'll outline it for you. If you send me an email.
Okay. Could you put your email in the chat box?
I don't know how to do that.
I'm not the only one.
Say that again.
John has your email.
Yeah, I do.
Yeah.
John has the email address.
I have your email address.
Yeah. I'll be happy to outline it for you.
Dr. G, I have a question. Are there any like general exercises that are recommended to to ensure blood flow in the foot is, doing what it needs to do. And
Absolutely.
oh, there are, okay. And the second question is, you talked about women getting a pedicure. When you go to a podiatrist, do you all do pedicures?
No, I don't do pedicures.
Okay.
But if a patient's a diabetic, I'll do the best I can to try to make sure that they don't go and have the other person digging around their cuticles or something, because that's tended where they get nicked, or trying to cut the nail out of the side or front. I'll try to do as much as I can to help them. And a lot of times they're fine with that, where they just want to have their nails painted and all. And we come to an understanding. It's kind of individual approach to come to an understanding, and I'll tell them based on what I see, what to not let the person do versus what to let the person do, and they seem to be pretty comfortable with that. As far as the exercises, there's a couple things that you can do. Moving your ankle or your toes towards you in a way. You can do it sitting, you can do it recline, you can do it even in bed. Wiggling your toes back and forth. If you don't want to spend the money on an elastic band, those bands that you can do isometric exercises to kind of pull stuff, you can use a pair of pantyhose to do the same thing with, or a towel. Even just sitting in a chair and wiggling your toes back and forth where your foot goes up and down. And if you're sitting, get up and move around some, because your knee gets bent and the blood flow gets compromised. So it's better to to do things in that manner. I'm doing it in my shoes while I'm talking to you right now, because I've been sitting for a while. So I hope that answers your question.
Dr. Jeter,
Yes,
this is
it did.
Rochelle.
Thank you.
This is Rochelle Brown. I have the side effects from chemo. I have neuropathy in my still in my toes, and they my doctors recommend that I go to the nail clinic to get my toenails clipped, opposed to getting a going to a nail salon to get my toes done. And they said if I want to go, I can let them paint them, but don't let them cut them.
How long did you finish your treatment?
I'm 6 years, and I still have neuropathy in my big toes.
Has it gotten any better, or has it stayed the same?
No, it's not as bad as as time going, I still have like little numbness in my fingertips and in my toes. So that's just, I guess that's just the side effects of chemo, just getting out of your system. They said it takes time.
Yes, it does. It usually doesn't take that long in my experience, but yeah, I've noticed that over the last couple of years, it's taken longer and longer, because I think a lot of the treatments they have changed some. So it's given more of a residual effect of the neuropathy, because I'm seeing that a lot more than I used to. But you're doing the right thing, and continue and make sure you do the daily inspection. After you've been out during the day, you come home, you look at your feet to make sure that you're using visual inspection to help you as well. Okay.
Yes. And I, like the rest of them, I have changed like the type of shoe that I wear.
Absolutely. Sounds like you're doing the right thing.
Dr. Jeter, when I went to you, you insisted that I change the type of shoes that I wear. Why is that important?
Because the shoes that you were wearing didn't have much support to them, and you have the type of job where you stand for long periods of time and you're constantly moving, and your feet needed more support to allow you to continue to do things that you do. And so to protect you and to give you those options, that's why we did what we did. And then, your feet, you've been standing for a long time, so your feet are a product of what you do. And over time, they need more attention, just like anything else does. So I remember you praised me and scolded me at the same time. You said, "Oh, my feet feel so much better, but these shoes cost so much money."
That's true.
Dr. Jeter, what do you think about the shoes Crocs?
You got to be careful with them. I used to wear them and I used to trip all the time when I wore them. People tend to trip in them. There was some couple of cases where kids got caught. The tread of the Croc got caught in the escalator. I'm not a fan of them. They changed their routine a little bit because the things that they had out, they had holes in the top of them. That wasn't necessarily good for people who had jobs that could drop stuff on your feet. The beach is one thing, but on a daily basis, I'm not really a fan of them. I had a problem with them. I tried them because they sent me shoes to try, and I kept tripping in them. And a lot of people trip in them. And a lot of people wear them because they're okay to wear. And I saw somebody wearing them the other day, had them on the other day, and they had worn them down so much in the heel, they didn't realize that their heel was really walking on the ground. And I asked them, I said, "Did you see what's going on?" "Oh, no, I didn't see that." So I'm sorry, but I'm not that much of a fan of them.
Dr. Jeter, what can you do to provide more support to your feet? I know they have those inner soles that you can use. Do they really help as much as some people say they do?
It depends on what the problem is. Just like I have on reading glasses now, and somebody else has on some other pair of glasses. So I'm not always a fan of one size fits all. When I was president of one of those things Dr. Callender was talking about, we sent Dr. Scholes a letter protesting the fact that you could walk into the CVS, stand on a box, or Walmart and stand on a box, and out comes some kind of insert, not looking at the patient as a whole. Did the patient have neuropathy? Are they overweight? Do they have poor circulation? There's a couple insoles that are over the counter that are pretty good. A lot of times, though, the person may need something that's more prescription, that's designed for their particular foot, just like everybody can't go to CVS or wherever and get readers. People need bifocals, people need progressives, people need whatever their prescription is with their eyes. So the same concept should transmit to their feet as well. But I do have people get over the counter things, don't get me wrong. It's just that it depends on what their problem is.
Thank you.
Dr. Jeter, my question is about flat feet versus feet that have a high arch. Can you talk about that?
Sure. Most of a large percentage of African Americans tend to have a flat foot structure. Is that necessarily a problem? No. Does there always have to be symptoms associated with it? The answer is no. It depends. A lot of times a high arch in a person may mean something else. There may be some neurological activities that made that happen. It may just be structure that everybody in their family has a high arch. The high arch is harder to control because it tends to be more rigid. I see more high arch feet in men than I do in women. A flat foot, I have a lot of people who have flat feet, have no symptoms, no problems whatsoever. But now if that person that had the flat foot, say, fractured a bone in their foot, then the flat foot may add to the problem with the fracture. So they kind of bounce back and forth. To protect the structure most of the time, to just stay in something supportive. If you have a flat foot, it's harder to stay in something supportive if you have a high arch foot, because it tends to, most of the pressure tends to go on the heel and the forefoot, and the arch is totally out. So a male who has a high arch foot is going to feel better in a lace-up shoe than a slip-on, because they tend to want to walk out of the slip-on. A woman who has a high arch foot is going to feel a little bit better in a slight heel than a flat. Did I answer your question?
Yes, you did. And the other thing was that some of the high heel shoes that women wear, it seems as though that creates a higher arch. Is that true?
No. It may push them forward a little bit. What I tend to tell the female patients, because if you look at a heel, it has the heel part in the back, but if it's real flat in the front part, then that tends to push them forward. I tend to try to get them to have a heel that in the front has more sole to it, where the sole is thicker, where it tends to push the foot back some to take some of that rock that you're talking about off. And they tend to feel better because it tends to push their pelvis back a little bit, and it tends to push their knee back a little bit too, so that they're not pushing, because all of those structures around the knees and the hips have to work harder when that happens. So if they have more sole in the front part of it as well, in addition to the heel, and drop the heel down a little bit. And then the block heel is a better heel anyway, not the narrow heel. If the heel in the back is more square, almost like a block, that tends to give them more stability as well when they come down and touch on the ground.
Let me ask you a question, Dr. Jeter. Was heels something that was created so that the podiatrist could survive? Or were heels created so that men could enjoy the posterior of women?
I would tend to say all of the above and then some. I think it started in Japanese culture, where they had binding, where they would wear those different heels, and they would actually bind a woman's foot and wrap it, where trying to make it a 4 or but both of those other ones are okay too.
It was also a part of Renaissance culture where men wore
Yes,
just as much as women.
that's exactly right. Yeah, that's true. But you don't see even, yes.
Dr. Jeter, I have one question about the callus or the extra skin that's on your feet. I know sometimes musicians, if they're playing a bass or a violin or something in their fingers, and they can get callus on their fingers if they're playing a string instrument or something like that. And that's I think your body way of building up extra skin layer. So it won't. So what about your feet? Because when you go to a podiatrist, they always shave all that off and they say it looks ugly. But the callus or that extra skin that your body is building up to protect it, is it really there to protect it, or it's just something that shouldn't be there, callus, when you have it on your foot?
It's usually related to excessive pressure in that particular area. So it forms because there's more pressure in that area than other areas. So your skin is trying to adapt to that. The problem is when it gets to be too much, because of whatever the person is doing is repetitive. So then it builds up more than the skin can slough off. There's some things that work with that. It's called Kerasol. It's over the counter, KERASOL. It has urea in it, and the urea helps to break the callus down some. That works really well. I have patients put that on at night, usually before they go to bed and sleep with a footie on. But if a person has a other underlying condition like diabetes or on dialysis, they have to be careful because that excess pressure can build up more and create a sore or an ulcer in that area. So a lot of times what they'll try to do is redistribute the weight. It's hard in the hand, as you gave an example of a person that was playing a musical instrument, but in the foot, you can redistribute the weight a little bit different. In that regard, a lot of football players, especially big linemen, have that problem because they're so big and they put the pressure on the same area, usually under the big toe joint, and it creates a lot of friction under there. So sometimes we try to modify the shoe a little bit to take the pressure off of that area.
Do you recommend shea butter as a good foot moisturizer?
Oh, absolutely. 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 Now, a lot of times, especially women will complain if the shea butter is a little oily with it, if it has another component to it, then it will tend to stick to their nylons or their knee highs. So I'll tell them if that's what they prefer, to use it at night. Yeah, it's fine.
Yeah,
it works really well. Actually, I'll have people, if they have, go ahead.
Yeah, I use pure shea butter and I don't find that to be oily.
That's fine. That's fine. And if the skin is really excessively dry, especially sometimes around the heel, I'll tell them to use that and then put Vaseline behind it, because the Vaseline will drive the shea butter into the skin more. So,
Dr. Jeter, I have a problem at night with my feet. When I'm usually only when I'm in the bed, they will get really hot for a while, then they will get cold, then they will get hot, then they will get cold. I have a tendency to throw the cover on and then throw the cover off. So does that have anything to do with circulation, or is that just I don't know. But it's been happening for quite some time. I remember my mom saying that, and I don't know whether that's just old wives' tale, that her menopause rested or landed in her legs and feet. And I kind of thought that maybe it did the same for me, but that has been a pressing problem ever since I started menopause as well.
yeah, I hear that quite a bit, actually.
Oh, okay.
And it's more likely related to that. The other side I hear from diabetics is that they complain of their feet being cold at night. But their feet usually aren't cold at night. It's the nerves playing tricks on them, making them think their feet are cold.
I'm not a diabetic.
No, I understand. I'm just drawing a parallel. Now, the fact that it's getting hot and cold is probably what you mentioned, as opposed to anything else. I would tend to suggest trying to, before you lay down, to just do a few exercises to your feet to see if that changes the dynamics of what's going on. Okay. I don't know the answer to that question, but I would be curious to see and to let me know that if moving things around before you rest if that helps the dynamics of it. I'm writing a note about it because I'm gonna look at it myself because
Okay.
I've been hearing that a lot lately, and I've actually witnessed it.
Okay. So mom wasn't exactly wrong.
I don't think so.
And the other thing I wanted to say, you were talking about the fungus on your nails, and I have experienced that as well.
Yes.
And it didn't
What
cure
about
the fungus, but I noticed that I started putting tea tree oil on my nails, and it cleared the coloring. It helped to clear the coloring up, but the thickness of the nail is still there. Maybe not quite as much, but the tea tree oil did help the tea tree,
tea tree oil?
TEA
Did you say tea?
tree oil helped to clear the coloring up.
I didn't hear what you said.
Tea tree oil, TEATRE.
Did for better.
Say that again.
No, I understand what you're saying. The
TEA. Like the tea that you drink. Tea tree.
TRE.
TEATREE. Oil. John, put that in the chat box. I'm like Dr. Jeter. I don't know how to do that. Yes. Put another E on the end. Tea tree, and it's two separate words.
Hey Betty, tea tree oil, they
Yes.
say is used as a anti-fungus essential oil.
Okay.
And so maybe that is what
It
cleared
has
it up.
helped to clear it up.
Yeah, a lot of those in the natural hair community, when they make these, concoctions, we use tea tree oil to ensure bacteria does not build up in the mask or whatever we're trying to make. But it is, Dr. Jeter, it is an essential oil that they say is anti-fungus.
Okay. Well, it has cleared the coloring up on my toes.
Yes, I'm back. I got kicked out.
Okay. So did you hear that?
He got kicked out.
Yeah.
I was kicked out, but I'm back. Yeah, I was trying to say the purer the tea tree oil, the better it is.
The purer.
Oh,
okay.
Yes, the pure. A lot of times you have to get it online because some of the ones have a lower percentage, 25%, 30%. But the purer the oil, the better.
30 milligrams. Yeah. It definitely has helped the coloring.
It will definitely. Yeah, and in addition to using that, what you could do while you're using that, if you take some apple cider vinegar, take a couple capfuls of apple cider vinegar and put it in room temperature or warm water, and soak it maybe a couple times a week, and then use the tea tree oil. In addition to that, the apple cider vinegar acts as it breaks down the fungus too, so that'll probably speed it up a little bit. Okay. And those are more holistic approaches.
Okay, thank you.
You're very welcome.
If there are no more questions, I want to thank Dr. Jeter for spending so much time with us and answering all the questions. Sorry that we lost your slides, but you made up for it with the quality of your presentation, and we appreciate it very much.
Amen.
Anytime. And please make sure they get my email. So if anybody has any follow-up questions or anything, I'll be happy to answer them for them.
Yes, everybody can click on the chat down at the bottom of their screen, and they will see Dr. Jeter's email.
Okay, well.
Thank you so very much.
Yeah, thank you for honoring us with your presence. Thank you for such a quality presentation.
Thank you.
Thank you, Dr. Callender. Thank you all.
All right.
Yeah, thank you.
Thank you.
Have a good day.
Okay,
Thank you.
Bye.
thank you.
Well, any other issues we need to talk about before we say goodbye for
I
another week?
think they finished with it. Yeah. You done with the rest of that?
Perlene just muted. Okay.
I have an announcement. If you're looking for a booster shot, Sports and Learning Center are doing them.
That's
Okay.
exactly right. And they're doing your first shot as well. And I
Sister
understand.
Sylvia gave me that.
Yeah, they do all the shots. So they do Pfizer. Dr. Callender,
Yeah.
somebody asked me if they had the Moderna, can they get a Pfizer booster?
And the answer is actually no, because the FDA authorization is only for Pfizer for now. Now, eventually that will change, but right now, the answer to that question is no. Now, however, another aspect of that is if it's toward the end of the day and the medicine is ready to be thrown away, then that's a situation where, yes, they would be willing to give you the medicine, even though it's not approved. But so the FDA approval is only for the Pfizer, but rather than throw the vaccine away at the end of the day, it could be given to somebody under those circumstances, even though it is not FDA approved.
Right. Well, I gave them the right answer. That was Emery Andrews.
Hey, as I went to get my booster day before yesterday at the Prince George's Sports and Learning Center, and there were no lines, and you need not have an appointment.
Thank
And
you
do you
very
have
much
to
for
be a
that.
member? Do you have to be PG residents?
No, they indicated anyone can come in.
Including people from DC.
Yes.
Do you have to show that you have been vaccinated for those 6
Yeah.
months or 8 months or whatever?
Yeah, you have to bring your original vaccination card. And, I like maybe some of the others had laminated my card thinking that this was the, but what they did, they took my laminated card and they gave me a new card. So don't laminate.
Don't laminate.
You never know.
So when I got, they encouraged lamination. They even told me that Staples would do it free.
Yes.
And they
Got my
did.
shot.
I had a big argument with that about my sister, and they advertise, oh no, you can do it free, and they'll give you a donut if you go to Krispy Kreme. She laminated, and I said, Dr. Callender said, do not do that.
Right. Anyway. Yeah,
I may have missed that meeting, but
I had mine
they
done
took,
before.
yeah, they took the laminated card and shredded it.
Yeah, well, you did miss that because we did say that on this group session. Do not laminate.
Right. Yeah.
And take a picture of it in your iPhone and put it in your. I have a thing called Notes, and I put a picture of mine in my phone.
Right.
All right.
Good.
Dr. Callender, I saw you on Channel 4 again. They were
So did
honoring
we.
you this week.
Did too.
So did we. So did we.
Yeah.
Thank you. Yeah.
And how come you won't tell us about it?
Actually, I sent something to John too.
Oh, so John didn't tell us.
Oh, okay.
I sent to John thinking that John would spread it out. But yeah.
I got your song that you sang at the funeral.
You do everything, huh?
Yeah, it's been my month, September.
So were you just honored once on Channel 4 or some other times this month?
No, well, the Howard University put out a press release, and it was picked up by a number of areas in some newspapers and I think the Washington Informer had an article on it, and I guess there's a number of places that picked up on it, not that many. And then, of course, Channel 4 picked up on it as well. So they all did it independently. But it was interesting, the timing. Because
So
most of
is
it,
Howard going to start the transplant?
no, it had nothing to do with that. This was just the fact that I received the Pioneer Award, which you knew about.
Right.
And they just acknowledged it at that point, that's all. Yeah. Okay,
Oh,
well,
one other person has something about, and I've probably heard incorrectly anyway, but I don't think there's approval for children 5 to 12 yet, right?
no, not yet. It's not been authorized for 5 to 12.
Okay.
Close.
Getting closer though, but not yet.
Do you think it'll happen before October 31st?
Well,
I think
okay.
it's likely. It's likely because I know I saw a release that it had been, the data was good, but it had not yet been FDA approved. But the data is excellent so far.
Pfizer submitted it for FDA approval, I think it was last week, but FDA typically has a 4 to 6 week review before they approve it.
Yeah. So it's likely to occur before the 31st of October. But we have to wait and see. Okay, well, you folks have a good week and we'll see you again next week.